Hi, welcome to Zoomustahan sa SLUNAAI. I am your host, Kay Retardo. This is our monthly event that we host for our alumni and SLUNAAI friends. It happens every third weekend of the month, and we hope you could join us on this monthly activities. We choose our monthly topics partly based on the results of the survey that we did with our members, as well as responses from our social media interactions. To know more about our future events, visit our website at www.slunaai.org or SLUNAAI group on Facebook and Instagram. And for those of us who are tuned in, good evening, good morning, wherever you are in the world, thank you for joining us. We would like to greet everyone, all the nurses out there, all of us here, belated Happy Nurses Week. Of all the things that we do every single day, it's almost like it should be Nurses Day every day. So again, from us here in SLUNAAI, belated Happy Nurses Week. I just wanted to give you guys a chance to just look over our Zoom housekeeping rules. I know that most of you are already used to this Zoom meeting, so just wanted to make sure that you mute yourself if you're not talking. Put it on speaker's view. Is recommended for a better visual of the presentation. Avoid distractions, and the chat box will be available for any comments or questions that you may have. This month's presenter is Dr. Armiel Suriaga. Dr. Suriaga works as an assistant professor at Florida Atlantic University, where he completed his Ph.D. in 2021. He received numerous awards such as Excellence in Service, Leadership, Scholarship Awards, and the JC Award for Extraordinary Ph.D. Student. In 2018 and 2019, he was selected as Nurse Faculty Scholar by the American Association of Colleges of Nursing, AACN, and Johnson & Johnson. In 2019, he received the Florida Nurses Foundation Edna Hicks Scholarship Award. He also received the Distinguished Alumni Award from his alma mater, the West Visayas State University, and an Outstanding Alumni Award for Nursing Service from Iloilo Science and Technology University, both in the Philippines. Recently, he was selected as a fellow of the Gerontological Society of America Career Mentoring and Development Program. Dr. Suriaga received several teaching awards, including Faculty and Staff Strategic Excellence Award at Florida Atlantic University. His research interests include healthy aging, transforming healthcare environments, substance use, misuse, and abuse, particularly opioids and cannabinoids. He's also interested in improving the nursing education pedagogy. He presented his research in regional, national, and international conferences and has published his work in peer-reviewed journals. Not yet finished, a few more things here to highlight. He is currently the president at Sigma IOTA at large chapter and the editor-in-chief of the official Truth newsletter. He is also a member of different professional organizations such as Sigma International Honor Society of Nursing, Southern Nursing Research Society, Philippine Nurses Association of America, American Nurses Association, and the Florida Nurses Association. He continues his education by studying epidemiology at Harvard University at T.H. Chan School of Public Health, where he starts on June 2022. In his spare time, how does he even do it? He enjoys gardening, reading, and traveling. Let us all welcome Dr. Armiel Suriaga.
Thank you very much, Kay. That's very generous of you. And thank you for inviting me here. It's a great honor for me to share with you my research and my work on opioids as one of the substances that I am interested in to further the research. Again, as I said, whatever time frame or time zone you are, good evening, good morning, or dito sa amin, which is evening, Florida time. All right, so my topic is on opiates and how nurses can help curb the epidemic. So I would like to share my screen with you. If you don't mind, I'll screen it, I'll share it. Okay. So for the time being, since my work in substance use, misuse, and abuse, I call it SUMA. This is my dissertation actually from FAU, and then I expanded it to numerous presentations and publications. And currently, because of my work on substance abuse, and AMERSA recommended me to be the chair for the nursing research interest group, and we'll be presenting this November for the conference as well in Boston. For this for this webinar with you, the objectives as we submitted for the CA units, we have to review, synthesize the role of opiates in clinical practice, particularly in pain management. Nurses, as we are, the critical role in pain management of our patient.
Dr. Suriaga, sorry to interrupt you. Will you be able to share your screen with the slide?
Oh, sure.
Oh, thank you.
Okay, I will do, I apologize for that slide. Okay, there it is. So another objective is to identify the population at risk, and later on I will highlight the results of my research in terms of who are at risk in dying from opioids. And also we have to review the evidence-based practices for pain management, including the non-pharmacological approach or interventions, including the medication-assisted therapy. We also explore harm reduction strategies, including the exchange syringes and the community inclusion to curb the epidemic. Again, the role of nurses will be highlighted, particularly the role in patient education or the health educator part. So the content of this presentation, as I said, the first one is to understand the opioids crisis, the epidemic, how it started in the United States. And not only in the United States, the problem happened in opioids, but worldwide. And the role of opioids in clinical practice, who are the vulnerable populations, including the one who will be presenting the older adults. As I said, the evidence-based practices and how we nurses can help address the issue. Another one here for this, one second, my screen will not move. Okay, okay. Okay. Okay, so, oops. All right, so now here's the background. How did the opioid epidemic started in America or in the US? There are three waves here. And understanding of the opioids started in 1999 when there's a rise or increase in the opioid overdose deaths. That's the wave one. We have the opioids like the morphine, the oxycodone, OxyContin, fentanyl, and it ended up in 2010. There was a rise in heroin, which is the illicit opioids. So they say that opioids could also be a gateway to other drugs like substance of abuse. So the heroin increased in 2010. And as you can see, heroin deaths continued to increase even during the pandemic. In the wave three that started from 2010 all the way to 2013 and until now, we have the rise in opioid overdose deaths, particularly in synthetic fentanyl and other opioids. So as of the age distribution, we are always, what is popularly known is that opioids affect the younger population, particularly those 18 to 24, 25 to 34 years old. However, in my research, there's a persistent increase in the opioid deaths among older adults, or we call those people 65 and above. Although 65 and above population constitute only, the proportion is quite small, like 3.4%, in contrast with 20% with younger populations of 25 to 34 years old. According to some studies, as I said, I focus on the gap in research, which is the older adults. But we will discuss the age distribution, which I said mostly affect the younger, the young adults. So as Kaya reminded me to make this more relatable to our discussion today, in terms of race, in the context of ethnicity, opioid overdose deaths by race, as you can see, it affects mostly the non-Hispanic whites. There's a big proportion there for the non-Hispanic whites, making up the 70% to 86% of the cases of deaths for this research, followed by the African Americans or Black, non-Hispanic, then Hispanic, and you may ask, where is the Filipino um, in this context? We belong to the other race in here, which is the Asian Pacific Islander, even the other races like American Indian, which in some research would show that high percentage as well. However, in the nationwide, the white, the non-Hispanic are mostly affected by the opioid deaths, which is in some studies showed that because of the cultural beliefs and practices of other races like Filipino Americans or even in other races, even especially in among blacks, the culture of we're not relying mostly on drugs or medications to treat our pain, but rely on prayers, meditations, or other non-pharmacological interventions. It may explain the reasons why the prevalence or the incidence of opioid deaths is not more among the other races than the white population. So in terms of prevalence, as I said, in the United States, these are the opioid death rates. Florida is one of them, the highest of deaths, opioids. Then followed by other states like New Mexico, Arizona. This blue, like California, it's like they have the 16.1 to 18.5 deaths per 100,000. So in Florida, we have 21 to 57. So we have one of the highest here, all the states, like even in Michigan, Ohio. So they are mostly affected by opioids, although the problem is globally and nationally, but there are some states that are really, the prevalence is very dramatic. Okay, so here I just see that the cause of the opioid overdose deaths or epidemic can be explained by overprescription of opioids by the medical practitioners, like your medical doctor. And as you can see in some of the videos, like the Hulu, you have the dope sick there, and putting the I wouldn't say the blame, but the causations of opioid epidemic because of over prescription by doctors and also the overemphasis on pain. As you can see in the 1990s, there is a big push to address the pain of the population. Even JCO or the Joint Commission initiated the move to for nurses and for the medical practitioners to address the patient's pain, because if you're not addressing the pain of the population, then we are not meeting their needs effectively. And pain, if it's not addressed, can increase your blood pressure and can also interfere with the healing process, particularly those with fracture and other comorbidities. So the overemphasis on pain is one of the factors that may lead to the opioid epidemic. Another one is that because of the magnitude or the prevalence of Americans with chronic pain, 25.3 million Americans, and even more than half a million Medicare and Medicaid beneficiaries, they have chronic pain. And with this issue, pharmaceutical companies see it as a big opportunity for them to market the product, the analgesic, opioid analgesics, to address the pain, which is the outcry during the 1990s. And when you can see the causations there are some drug companies that benefited from the crisis or contributed to the crisis per se. And because of the promotions of opioids as the gold standard for pain management, the proliferations of opioids from oxycodone, oxycontin, morphine, fentanyl analog, even heroin as part of the illicit opioids became problematic to most people. Then, as I said, pharmaceutical companies like this video, the Purdue Pharmaceuticals manufacturing the oxycontin, play a big role in the proliferations of the opioid use, leading to the epidemic. So in Florida here, with our regional, statewide problem, the pill mills were a gateway to the opioid crisis. What do I mean by that? There are some pain clinic in Florida that's being the root cause of prescribing a lot of opioids to patients, and some of the patients came from other countries like Canada. They came here in buses, and they were prescribed opioids like 30-day supply or more than that, and they came here with a bus load. They go to the pain clinic. They've been given. Sometimes they pay cash, so it's hard to track. But and this opioids that proliferate in the market, and even to patients, when you go to the hospital, they give you a bottle of opioids. But now, because of the crisis, they put a stop on those practices, and they crack down the pain clinic, and most of them are closed. And some doctors face legal problem or the lawsuit because of the role in the opioid epidemics or crisis, not only in Florida, but in the United States. I want to emphasize that the opioid crisis could also be a result of the socioeconomic despair. What I mean by that, some researchers or scientists believe that the crisis of opioid is due to economic despair. People lost their job, or they have no significant gains from the economic situations, especially in the US. This is more happening in the rural areas where people may have no advantage in terms of income, educations, and they don't get a job properly, or they have a job that is more of the labor side and causes a lot of pain. So they switch to, they use opioids and become addicted to it, or because of the depression, anxiety, even PTSD among veterans, they use opioids to cope up with their problem, not only physiologically, but also with emotionally. So this is the one of the models or pathways of the social determinants of opioid overdose deaths. And this is where I get my idea when I do my dissertation, that opioids is not only caused or due to overprescription by the pharmaceutical companies and eventually with the prescribing doctors or medical practitioners, but because of the role of or factors we call the social determinants of health, such as education. Low education, in my research, showed that people or counties with low education, high school and below, they have a greater odds of increasing opioid death rates in that particular county. So in opioid death rates, we calculate that number of deaths from opioid as a cause of death multiplied by 100,000 divided by the population in that particular county or area. So that's how we calculate opioid death rates. So because of the low education in that county, it increases the odds of opioid death rates. I also examined the role of job, income, median income, race, either Hispanic, Black, whites, and others, or Asian. And also the poverty, percentage poverty in that county. And education became, there's a statistically significant correlation of low education to opioid death rate. As you can see here in the model, even in the Rust Belt states, for example, in Florida and Michigan, Ohio, with the high opioid death rates, opioid overdose deaths, unemployment, recessions, and then the weakening of the unions and the decreasing worker power contribute to despair of these workers. And as I said, they have pain because from the labor or from their job, and because of underfunded schools that underperform, and also veterans, as I said. These are the populations are vulnerable to getting opioid prescriptions from the provider. with that cause, it propelled the providers to prescribe or overprescribe opioids to them to meet their needs. And also the weakening of social support, like for example, there's no family contributing to depression or weakening support and isolation, and community of despair, especially in the rural areas with less job, uh, predispose these counties or this individual to take opioids as a coping strategy for them. And because of the psychic pain, normally we don't prescribe opioids with psychic pain. However, as I said, because of the psychosocial issues, some of them turn into opioids. And we prescribe opioids because of the neuropathic pain, because of the physical injury, or the physiologic issues that the patients may have after surgery to the bone or due to cancer. All right, so let's examine the role of nurses, our role in opioids, I mean, the role of opioids in pain management. As you can see, or I discussed earlier, that opioid is the gold standard for severe pain. There's some argument that opioid may not be good for moderate pain, because when we ask our patients what's your level of pain from a scale of 1 to 10, and when they say that their pain is between 7 to 10, shall we say 4 to 6 is moderate pain, and then 7 to 10 will be a severe pain, depending upon the agency protocol, then the doctor or the provider prescribe opioids to them. Nowadays, even the hospital, when it's talk to nurses, even before they go to the OR, they utilize the NSAID, tramadol, and instead of opioids to respond to the crackdown of opioid overuse or overprescription. So they sort to different strategies to reduce the use of opioids. However, the opioid is very effective in treating pain. As I said, I attended a conference this week in Orlando, but a conference about cannabinoids. But one of the topic there is about the role of cannabinoid in reducing the use of opioids, because cannabinoid can be also used for analgesic. However, one of the speakers there said that we cannot avoid prescribing opioids to people, especially those who are hospice with pain, cancer pain, and those with chronic pain like more than 3 months or 6 months, indurations, those people with arthritis, fibromyalgia, a lot of conditions, cancer, they cause a lot of pain to our patients. And opioids, we cannot avoid not to prescribe them because it's more effective to that regard. However, we need to identify people who are vulnerable to developing tolerance to addiction from opioids. So the role of opioids in pain management is well established. However, later on, I will discuss which opioid drugs or medications are causing more harm to a certain group of people, and also which opioids could be agonists and antagonists in addressing the tolerance or addiction from the drug. So here, the use of opioids in pain modulations, I teach pharmacology and pathophysiology, and the way the opioid works, it binds with the opioid receptors, the mu receptors in the brain, and then when it enhances our endorphins, which is our endogenous opioids in our body, we have the endorphins. Without the use of medications, the external or the exogenous outside source, our body can modulate the pain using the endorphins, the enkephalins in there, and then when they bind to the receptors, it activates that effect to regulate the pain of the body. However, as I said, our brain interprets our pain sources. For example, we got a cut, we got injury to the tissues, to the muscles, even to the nerve, and then the nerve gives signals to the brain and then releases all these endorphins or to modulate our body's response to the injury or the pain. So when we cannot tolerate anymore the pain and our body is responding to it, then the doctor prescribes the exogenous opioids in the form of morphine or other like fentanyl, oxycontin, to give reinforcement for our body to cope up with the pain. And as Macaferi said, as nurses, we have to listen to our patient, and when a patient complains of pain, that's a subjective symptom. Pain, it is what it is for them. And the reality is, whatever the patient perceives as pain, we have to believe them. So that's where our role here, the opioids could modulate the pain, and the patients will tell us about the pain or their non-facial or non-verbal expressions of pain, like grimacing. And we have to make a judgment which level of pain that they are experiencing at the moment, and we give prescription or medications based on the order of the provider. So here we can see that opioids work effectively in pain modulations, particularly severe pain. And the common opioids that we are familiar with, we have the hydrocodone, Vicodin, oxycodone, hydromorphone, morphine, codeine, fentanyl, methadone, and buprenorphine. In my research, I examined 13 opioids, shall we say 1, 2, 3, 4, 5, 6, 7, 8. 8 here. I also included heroin, the incidence of deaths from heroin. Then we have oxymorphone, also included that in the study. So I will show that to you later on. So the effects of opioid use and misuse. So when you use opioids, just like any other drugs, it has side effects. However, the adverse effect of opioids are well established, like your physical dependence. It causes tolerance, wherein you need more dosage to achieve the same results, like pain relief. And also opioids can cause common side effect like constipation. The anticholinergic effect of the drug can cause nausea, vomiting, sedations, dizziness, and respiratory depression. So we teach our student nurses, we teach our nurses that when there's a drop in respiratory rate, for example, below 12 breaths per minute, we have to be mindful that if they're taking opioids like morphine or fentanyl, we have to closely monitor the respiratory rate. If it continues to drop, then we have to administer an antidote called naloxone or Narcan. So we have here also that opioid use can be misused, meaning to say that they are not following the use of opioids prescription-wise, dosage-wise, frequency-wise. It becomes a misuse. Or the intended purpose of opioids may not be the primary reasons why they're using opioids, because they are taking it from the street or from other family members who may have an stock of opioids in their home, and they shared opioids, is one research showed, and it can cause a lot of sharing of drugs. This drug can cause psychological addiction, meaning to say you're craving emotionally to the drug. It can be a substance of abuse and diversion. As I said, you're being diverted. And some, unfortunately to say, that there are some nurses or healthcare providers that may be diverting the opioids, and they're using it themselves. That's why we can have this rule in our facility or agency that if you are acting as if you are under the influence of a substance, they can do some drug tests with you or with a person who's been suspected to be using the substance. In people, 10.1 million people aged 12 and above are misusing opioids. They misuse opioids in 2018, and in the US, 9.7 million people misuse prescription analgesics, including opioids. So the problem is so wide and so big that people are using opioids, a lot of them, because as you see earlier, 25 million with chronic pain. And then if a lot of people are being prescribed opioids, and 9.7 million in the US develop misuse from opioid medications, then we are looking for a grimmer or not a very positive outcome of opioid, because they will go into addiction, they will go into overdose, and eventually death. In the ER visits or emergency room visits related to opioid overdose, it increased by 30% from 2016 to 2017, and the national rate of opioid hospitalization was 297 per 100,000 population. So if you translate this figures into economic cost in addressing the opioids, in one research, it showed that over $1 trillion that the US government spent already for opioids. In 2018 alone, $78 billion has been spent to address the opioid epidemic, including the treatment, including the family. When you lose a loved one from opioid overdose, and you are left with children to take care of them, or to with a legal battle, then it costs more. However, if you put in the social determinants of opioid deaths, including the effect to the individual person, you cannot quantify. It's hard to quantify the cost of opioid crisis, because if you lose a loved one, there is no price tag to the loss of life. Then we have your opioid use disorder that may happen from misuse of opioids. So when you have a disorder, mean to say that opioids become a problem in your daily life, in your daily functions and activities of daily living, from your job, academic performance, or even your workplace. It becomes a disorder because or you are over relying to opioid to address your issue. So it occurs due to the chronic use of opioids that cause clinically significant distress or impairment. And the basis of that criteria is based from the Diagnostic Statistical Manual 5, DSM-5, and this is the criteria: persistent desire, unsuccessful efforts to cut down or control opioids. Opioids are often taken in larger amounts, for example, more than 50 microgram of morphine, milliequivalent of morphine, and recurrent use of opioids in situation which is physically hazardous. People know that they have already respiratory depression, or they have pinpoint pupils already, and they continue to take opioids to the point of death. So also people experience withdrawal by these characteristics, like they have the withdrawal syndrome, or they're craving for the drug. Then it becomes a disorder for other people. And as I said, as nurses, how do we identify people at risk for opioid overdose? In this study, okay, you can see people with chronic pain, as I discussed earlier, 25.3 million people in the United States have chronic pain. Most of them are older adults. And also those people with anxiety, depression, they are prone to overdose with opioids. All right, and also this research by O'Donnell in the CDC. We have males, the incidence of opioid deaths are very prevalent. Here, more than 69% compared to female, 30. So death from opioid overdose occurred more in males than in females. White, 78% compared to Black, and Hispanic, 6.9%, and other, including the Filipino Americans, other Asian, Pacific Islander, 1.8%. That is only opioid without a stimulant. Okay, so even though with other drugs, research showed that less prevalent among us or among other races. But the most affected one are the white or the non-Hispanic white. And as I said, in the age group, the one mostly affected is the 25 to 34 years old, followed by the people in 35 or the working adults already, up to the 54 years old, and the older adults only like 4.3. However, this is where my research showed, my research focus later on. So here it is, my research focus is on the older adults. I did a systematic review of opioid use. I used to work in long-term care when I first arrived here in the US, in Michigan. And when I moved here in Florida, I examined that a lot of people, I observed that a lot of older adults, when they came from the hospital, they were prescribed with morphine, fentanyl due to pain from post-status hip fracture or hip repair or whatever musculoskeletal injury that they have. And a lot of them died. So when I did my dissertation, I noticed that there are a lot of other adults who cannot tolerate the who cannot, due to aging or physiologic changes, slow metabolism, they're at higher risk of opioid overdose compared to the younger population. In older adults also, there are reasons why there are higher risk for deaths from opioid. They're 7 times more likely to be hospitalized than younger adults because of comorbidities, polypharmacy, because of aging processes, because of slow metabolism from the drugs. It causes a lot of toxicity, leading to overdose, leading to death. Same results happen. It happened in male. This is like cause of death from opioid. When I say the opioid is a cause of death, the medical practitioners define a cause of death as the drug plays a critical role in the death of a person through the autopsy, through the urine, through the toxicology results. And they found that these drugs like oxycodone, fentanyl, oxycontin are in the system or in the system of these persons at the time of death. So the same result, it affects male compared to female. Non-Hispanic white, in this older adults population of my research, 93% compared to the general populations nationwide, which is in the previous slide, we have here 24%, non-Hispanic white is 78%. In older adults, when during my research, is 93% died from opioids. So the increased risk of overdose deaths is higher in older adults. And also I explore what county they died. So metropolitan or urban counties here in Florida, my study is in Florida, okay? The whole state, I got the data from the Florida Department of Law Enforcement from 2014 to 2018. And then after my dissertation, I expanded my study up to the time of COVID-19. So here we have also the non-metropolitan, which is the rural areas. We have a few here in the Florida. We have 44 counties here, which is considered urban, like Miami-Dade, Palm Beach County, Broward County, Orange County, like your Orlando city there. They're belonging to the urban counties. A lot of that happened there. However, in the rural areas like Glades or Lee counties, we have only a portion, even like less than 4%. And what is very alarming in my research is that in the older adults who died from opioid, accidents is very high, 56%, followed by suicide from the drug. So there are some medications, opioid, that can cause deaths leading from deaths resulting from suicide or from accident. These are the opioid distribution in older adults, like buprenorphine, codeine, fentanyl, fentanyl analog, heroin. And the most one causing the death of the person here is oxycodone. You can see in the video, in the series, Dopesick, OxyContin, or oxycodone, Purdue company. So 23% of older adults died from this drug, followed by morphine, and also your hydrocodone. And here, as I said, related accidents of suicide, I explored how many of them died from codeine that results to accidents and suicide. So here it is, we have your fentanyl, 80, accidents and suicide 12. Analog, all of them died from accidents. And oxycodone, 101 older adults died from accidents, followed by suicide, which is very high. 129 older adults committed suicide while under the influence of oxycodone. So, and tramadol, some of us are aware that they may say it's less evil than oxycodone, but the trend continues to be increasing because in tramadol, 47 died from suicide, followed by accident as well. At this point, how nurses can help curb the epidemic. Before that, I want to emphasize the effect size of the research. When you speak about effect size, how is it really affecting how big it is? Moderate effect. So I examined the Kramer's D in chi-square as the cause of death from the specific opioids to the manner of death, like accident, suicide. And when you see the 0.4, 0.3, there's like a moderate effect, 0.6 large effect. So fentanyl and heroin does have a large effect here. With oxycodone, moderate effect, mean to say that there is a problem in the population that it has a moderate effect. In that, we need to be mindful what type of opioids that can cause more harm or death in a certain population or vulnerable population. In this case, the older adults. Tramadol may have a small effect, but still there's an issue in there. Same thing with hydrocodone. So at this point, we have to explore how we nurses can help curb the opioid epidemic. So in Florida, I know there are some states that also adopt the same strategy. Before a provider, a nurse practitioner who is working closely with the doctor or the provider, prescribe opioids, they have to log into the electronic records. We have the E-Force here in Florida that stands Electronic Florida Online Reporting for Controlled Substances Evaluation Program. So when the patient goes to their primary doctor or primary provider, and the provider may need to have a contract with the patient and promising that they will not be shopping other doctors for opioids prescription from other doctors. And then when they log into the electronic records, they will see if a certain doctor already prescribed an opioid to this person or to this patient. And then if the patient will say, oh, I didn't have any medications, and he was prescribed with 1 or 30 tablets or the quantity, which the provider believes is still sufficient to cover her or him in the next few days, then they check the E-Force and advise the patient about the use of opioids. And if they see the problematic pattern of the use, and they have this one-on-one conversation with the patient or the responsible party. And it helps because this E-Force reduces 12% of opioid deaths in the state. And another protocol or strategy that we can help as nurses to curb the epidemic is to follow the agency protocol when giving opioids. I know it's challenging for us nurses because some patients really insist of having the drug, even though the medication has been administered 2 hours earlier, they want another more dosage because they develop tolerance from the opioids. So we need to follow the protocol and not to bend with the patient. And if they want to talk to the provider, our role is to give them either you want to talk to their doctor or show them that you've just been given medications or examine another order like the use of NSAID and offer the non-pharmacological interventions as well. I know the CDC guidelines 2016 gave us the guidelines for chronic pain prescription of opioids. And this week, as I said, during the conference, they say that CDC has been soliciting advice or perspective from the provider if there is a need to update the guidelines because the problem is continuing and the deaths are increasing. And maybe we need to update the guidelines for prescribing the drug. And also our role here as a nurse is to conduct a good pain assessment. I know pain is subjective, it is what it is. However, we still have to do the pain assessment before giving opioids to the patient. And after that, we have to evaluate the effectiveness of drug. And we know that very well within certain time, 15 minutes, it's given IV or orally, then we have to document the effect or the result from the patient based upon their experience with the drug. As I said, as a educator, a nurse educator or faculty, we also impress our students the need for non-pharmacological interventions, examine that in the record. Do they offer therapy services, exercise, yoga? And you may say that they have no time for that. However, the doctors are encouraged highly by the CDC, by other regulatory bodies to offer these non-pharmacological interventions, and some research showing that if you are not offering this one, it could be a source of, or a potential problem later on, and they examine the medical records of the patient if this is so, if this is done or not with these patients who have been prescribed opioids. And part of that opioid educations, we give them pamphlets, or before they're discharged to a nursing home, discharged to a community dwelling places, we have to educate the patients about the opioid adverse effect. And as nurses, we make it like a layman's term. If your pupils become smaller or pinpoint, your lips become discolored, blue lips, fingernails like cyanotic, slow breathing, below 12 breaths per minute, unresponsive to pain, increase. We need to impress the patient. These are the signs that you are developing adverse effect or overdose from opioids. And when this happening, we need to also show them how to administer Narcan or naloxone as antidote for this adverse or untoward incidents. So when I went to New York as a mentor there for the substance abuse research education therapy, part of the NIDA funding that they had, I went to that London Health system, the hospital, and they showed us how naloxone is being administered to the patient, and the patient is given a kit, a naloxone kit, and they can self-inject or give it to the first responder or the paramedics, because it works effectively in reducing or for the harm reduction strategies by the government. And also we have the coordinate the MAT or the medication assisted therapy, like the use of buprenorphine, methadone for patients who are withdrawing from opioids because they are considered agonists, antagonists for opioids. All right. Prescription opioid drug monitoring system, as I said, this is the A4s that the provider use to track the patient that they are being shopping around for their providers in terms of getting more prescription opioids. Okay, these are the strategies from CDC. And these are the evidence-based strategies for preventing opioid overdose. As I said, I discussed naloxone distribution. We showed them the video, and when we train providers like nurses, the ER nurses, and some physicians who are they have this special license or training for substance use or the prescription controlled substances, they are good undergo additional training and certifications. Part of that is your naloxone distribution. And also we have your academic detailing, okay? How many units, credits that they have to do certain requirements when they are being certified for a substance use provider. Some nurses can get also special certifications for the addiction. And John Hopkins was offering that before. And when I'm about to apply for the King-1 award for my research, part of that is how we get the certifications for the opioid or addiction training. Then we have the screening for fentanyl and routine clinical toxicology testing, and how we get the specimen, a drug test, a urine for patient, and also for providers that will respond to emergencies, the 911 Good Samaritan laws. Some people are afraid to call 911 because of the implications with the law. And some people may say that, oh, they're afraid to call 911 to save people's lives or their friends because they're afraid that they will be positive to heroin or a Schedule 1 drug that may put them to jail or probably the law. So we have this law that protects individual who may call 911 for their friends who are having some overdose from opioids. And also the syringe services program, the safety exchange program. There are some clinic or centers that provide syringes. People will go there and self-inject, or instead of putting their syringe after use in the street or in the trash, it may cause a lot of injury to other people. And also this program is very effective in reducing HIV transmission from the syringe, the use of syringe in injecting drugs. And with the safety syringe exchange program, it showed that people who use one-time syringe can help reduce the spread of HIV and other infection. All right, for us nurses, we have to do your assessment as part of the nursing process. And one of the assessment tool that we use to identify people who are at risk for opioids and those that we can intervene briefly and refer them to appropriate providers. We call that as BERT, screening, brief intervention, and referral to treatment. And we conduct this assessment for those who are at risk for developing opioid use disorder or those who are at high risk for overdose. And once we identify them, we can do a proper referral to either psychologist, to their primary provider, or their physician. And also coordinate the resources in the community, like your exchange syringe program or naloxone kit distribution, all this kind of stuff are proven to be effective in reducing the harms from opioid use and misuse. So we also being taught how to approach the patient with a non-judgmental approach instead of calling them or having some negative attitude or perspective because they're using substances, controlled substances. It may affect the way we deliver care. So we still encourage nurses and other providers to be non-judgmental when caring for people with substance use, including opioid. And the use of the non-stigmatizing language, instead of calling them addict, alcoholic, we call them a person with alcohol problem, or a person with opioid challenge, or a person, so instead of calling them addict, or they're not defined by their conditions, there are still persons with big dignity. There are still persons they're still with full humanity. In the bottom line, they're still human being. So when we are caring for people with opioid problem, with substance use, we need to be mindful of those language that may interfere with their treatment. Because if they feel that we are not interested of them being of receiving treatment, they will not go to the treatment clinic anymore. So it will hamper or affect their outcome as well. And then, as I said, the SBIRT screening will be very helpful in identifying the patient at risk, and the role of the medication-assisted therapy, like the use of buprenorphine. And I know methadone is a question because you have a waiver when some providers prescribe methadone. They have to go to the clinic, to the special clinic with the licensing to receive this methadone treatment from opioid overdose. There are some facilities like long-term care facilities that they can administer buprenorphine, or the person themselves if they go training, or there's some that they can administer themselves and the nurses will document or record that they're receiving the treatment. All right, as I said, the use of language matter, and CDC acknowledged that, the National Institute on Drug Abuse acknowledged that the use of language can affect the treatment outcome. So instead of using habit that's abuse, we use the word use and misuse. Okay, so the term abuse was found to have a high association with negative judgment and punishment. And even in other research, cannabinoids, marijuana, as much as possible, we try to avoid using the word marijuana. Now we use cannabis. Cannabinoids, it's more scientific, they say, but it's found out that people who are being called marijuana addict as with negative connotation, it may affect the outcome of the person. And instead of calling them addict, as I said, person with substance use disorder or substance with problem with using opioids. Instead of calling junkie, we use scientific words to substitute that words that may stigmatize the person, that may alienate the person from receiving treatment. All right. So another role here, we have your education dissemination and community inclusion. As a researcher, we present our research to conferences, we present our research to webinars, to scientific annual meetings, and even publish our result to disseminate the information, the harm, the risk from the drug, from the substances. And I think it's part of our, when we submit grants or even with our program of research, part of that is dissemination. How do you share the findings, the result to the community? How do you involve the community leaders to buy for the or other stakeholders that they may use your proposed interventions, or they may utilize the result in their everyday practice, or to inform policy, and even to change the way they conduct their or they use evidence-based practice from the research. So here we have the primary interventions like the use of safe opioid prescription and the use of NSAID, or the non-steroidal anti-inflammatory drugs like your Celebrex, your acetaminophen, right? Or even ketorolac, and cannabinoids to reduce opioid use. Disseminate informations and implement the prevention programs like in conferences, as I discussed, and even giving a webinar on naloxone kit to the high school students or even to the community. Okay, so health professions training, continuing educations on the part of prescriber or doctors, NPs who wish to specialize on the substance use, misuse, or opioid, then they have to undergo continuing education. Then we have secondary prevention, like your drug monitoring programs, like here in Florida, we have the E4s, and the use of the SBIRT assessment tool to screen those who are at risk to developing opioid use disorder or overdose from opioid. Then we have the abstinence program. I know it's difficult to tell a patient to stop taking the drug. So we have medications to give them to address the abstinence issue. And also we have your neonatal abstinence syndrome, wherein the mothers suddenly stop using opioids and then the withdrawal problem happen. And then we have to introduce the use of buprenorphine and methadone to assist them from withdrawal. And the training of the paramedics, the AMS, to administer naloxone, and even to the person. Right now, they don't require prescription to get naloxone kit. Florida and other states, they have to allocate budgets for naloxone kit distribution to the communities. The goal here is to reduce harms and deaths from opioid. And also we have to collaborate with stakeholders like policymakers. Right now, as a fellow of the Gerontological Society of America, I represent GSA in the CPAP, or the Collaborations for Effective Prescription Opioids. And we are meeting every month with congressmen, senators there in DC. Good, it's online. Every month they present a case of opioid problem or the increased use or deaths in certain state or counties, and they allocate budget and whatever programs they approve to reduce the harms from opioids. So I'm part of the conversations there, and as nurses, I observe that we have the voice as well to inform our policymakers that which one matters in a certain community. So part of our research is to know where the issues are, like counties, cities, and so we can allocate resources and to inform policymakers that this one is effective or not. It may not be implementing right away because, as you know, United States, we have different agencies research, right? But what is very promising is that they value the opinion, the perspective, and even the research conducted by nurses, conducted by providers, researchers, scientists in the nation to inform policy and effect change.
Dr. Suriaga, I'm just, before you head to the next slide, Dr. Ramira have a question that I think it will be good to be asked now. Her question on the chat box is, why is there a limited access to medication assisted treatment of opioid use disorders such as buprenorphine, and how can we increase access to reduce or prevent opioid deaths?
Oh, very good questions. Buprenorphine, as I said, when providers are prescribing this MAT to the patient, buprenorphine, I think it's like there's a push to distribute it widely, even among providers. So they have a waiver, and you don't have to go to the clinic or specialized treatment center to get the MAT like buprenorphine, we still have issues with methadone because of the adverse effect it has on patient. And research showed that there's some training that needs to be done on the part of providers, even with doctors specializing in pain management, and even with other nurse practitioners, and they need a waiver to navigate the law for this. This is where our research showed our workshop on the 5Ms framework, especially like we identified a gap that even in nursing home, they cannot get methadone there. They have to go to that pain or clinic outside the nursing home, in the community, or in the next to the hospital that measure methadone because of the as I said, the policymakers, even researchers, believe that they need extra educations in terms of the degree or the impact it has on patient. If they are patient themselves or family members or caregivers will do it themselves, the adverse effect on the patient may be higher right now. So they need extra educations to get that licensing or certifications to administer. So, but the push is to expand the MAT program. So even patients can self-administer buprenorphine while they're staying in a nursing home or in a rehab center, or even the community dwelling, assisted living. They have to extend because they see that buprenorphine has less adverse effect compared to methadone. In my research, as you see earlier, there are people who died from buprenorphine, but it's only minimal. 3 deaths from older adults with buprenorphine who administered themselves compared to a lot in oxycodone or even with methadone. So this opioid agonist and antagonist, they are being monitored, but as I said, buprenorphine could be expanded widely, the use, because it showed that they can benefit from this treatment. The more people benefit, the better it is. I hope it answers the question. But the methadone, as I said, one research showed that it can cause some adverse effect to other people who may administer and doesn't know yet the adverse or the ramifications of the effect of methadone to them, to their body. I hope it answered your questions.
Yes, you did. But I still believe that we still need to increase access to those medications.
Yeah,
really, really important.
Yeah, I agree with that. Even our doctors who are in the addiction pain management, they are lobbying extensively with the policymakers to give them access with buprenorphine, with methadone. And they say that it can benefit if we are serious enough to address the opioid crisis, then give them access. Even before with naloxone, they don't want to get budget to distribute naloxone for free. And the issue of insurance propelled them that the deaths, we can save lives from naloxone. So a lot of states are mandated to distribute naloxone kit, even without prescription. You can buy that in the pharmacy or you get it for free from the Department of Health. So we have to distribute naloxone. But now they are under the impression that they spend a lot of money and they could not get the return of investment from naloxone because they say, where are the naloxones now? And we're still having a lot of deaths from during the pandemic from opioids. So we need more research on the effectiveness of naloxone. We know that's very effective, but where did it go? The one they say, does it go to the hands of the person, or if it's just being placed at home without being accessed during the real emergencies or on the timely manner? But it's another area of research. But I agree with you. We need to expand that access to MAT or buprenorphine, even to naloxone.
Yeah, especially if we have this opioid crisis. I mean, they should really work on those access.
Yes, I agree. Especially that millions of dollars have been allocated already to address the issue. Yeah. Then we need to be distributing those medication that works.
Yeah, it's an epidemic. Okay. I mean, they should treat this as like COVID.
Yeah, that's true. And the deaths of opioid. Oh, you're welcome. Thank you. So the deaths of opioids is still increasing, even during the pandemic. So here am I. I expanded my research, my dissertation and analysis on 2014, 2018, and then got the data from the Florida Department of Law Enforcement, and they provided me the data 2019-20. And during the opioid epidemic, we see that 100,000 Americans died from opioid for that particular year alone. In Florida, we have more than 2,600 people only in counties that I see in one of my presentations here, Tri-County. I only analyze in our areas here. I live in Palm Beach area. Then next to us is the Broward County in the Miami-Dade County. 2,600, almost 3,000 died from opioid as a cause of death in our county alone in 2020. So this week I presented the co-presence of opioids in cannabinoid because they say that cannabinoids can reduce opioids because of its analgesic effect. But again, people also died from cannabinoid because of addictive properties and other reasons from the marijuana, especially the synthetic one. So we have a lot of things to do in order to address the epidemic, but we can be of a partner here in curbing the opioid epidemic, as I said earlier, by focusing on who are the at-risk individuals or people who are prone to developing overdose or opioid overdose. And we focus also the type of opioid being prescribed. In my review, there's some problem there, especially in long-term care, that they prescribe fentanyl right away after being discharged from the hospital because of some patients have a high or severe pain. But that fentanyl dose is higher, or oxycodone, that morphine milliequivalent is higher than what CDC recommends. So in that case, more than 50 microgram or milliequivalent of morphine of that oxycodone and fentanyl can kill an older adults. So not only that we know the opioids, but we need to be more specific which opioids are being prescribed. Is there safe using the Beers criteria or being followed up or monitored by the provider? What is challenging also is that when the patient goes home, they're receiving opioid prescription, they have to have a physical prescription from their provider, and they will get it from the pharmacist. And some people argue that it's not enough because we limit the opioid access now to the patient. And instead of giving them 2 week supply or 30-day supply, they're only giving 5-day supply to 7-day supply, and then they have to ask the provider again for a refill. But again, providers are being encouraged to switch to a different drugs like NSAID or ketorolac or higher doses of Tylenol. Instead of giving them morphine right away or oxycodone, they are prescribed 800 milligrams of Tylenol to address the pain, and then switch it to or introduce other modalities for pain management. So this is the future directions we have, the use of cannabinoids to address the opioid use disorder, even with focusing on which county or areas with high prevalence. I know California also has issues with opioids, and even that can lead to different problems in society. There are some counties that are having more problems than the others. Same thing with Florida. As I said, we share problems in terms of the opioid crisis, and we have waste or I don't want to be sounding pessimistic, but years and years to come is still a big problem for the United States. And I shared my thoughts, my perspective with the policymakers when during our last meeting at CPAP, that maybe because opioids are not the only manufactured here in the United States, we have opioids from Puerto Rico, which is part of the US, but from China, from other countries, and how I know they're being monitored also by FDA or from the government regulations, but how could it be true that a 5 milligram of oxycodone or fentanyl is the same us here in the United States, could it be that we need to have a stricter rules in and where the source of the opioids and where the other illicit opioids coming from in the market or from other places outside the US. So that's one discussion that we had the last time we met with CPAP. Okay, at this point, I thank all of you for being patient with me, actually. And if you have time, no, yes, we have time. I'm open for your question. Oh, well, thank you so much for having me here, and maraming salamat po sa lahat, okay? And
We'll be
I am
in
really
touch.
honored. Yes.
Thank you so much. Thank you, Dr. Suriaga.
Oh, thank you.
Have a good night. Okay, next up, I know, thank you so much. We went over time, but there were just so many information that was shared with us. And I hope that you got some information that's helpful that you can use in your own practice. So we would just like to do some updates with SLUNAAI. So next one here that we will be talking about will be call for nominations. So we are accepting nominations for SLUNAAI Executive Board for 2022 to 2024 term. So please consider serving in a position that resonates with you and how you would want to keep the mission going. And we are so fun to be with. So please, deadline will be May 21st, tomorrow at 11:59 p.m. Check the information on our website. There are new dates already. So same city, just new dates. The 2022 annual conference has been rescheduled for July 13, Thursday to July 15, Saturday, 2023 at the Sheraton Vancouver Wall Center in Vancouver, British Columbia, Canada. Hope to see you guys there and stay tuned for more information. So if you are not signed up as a SLUNAAI member, please head over to slunaai.org and click join us. And we're also welcoming associate members out there. So we welcome everybody. So next one. Just wanted to let you know about our initiatives. SLUNAAI is now a California Board of Registered Nursing continuing education provider, such as the event today. Stay tuned for more CEU approved Zoomustahan in the future. So SLUNAAI is now a 501c nonprofit organization. What this means, approved by the U.S. Internal Revenue Service as a tax-exempt charitable organization, donations, personal and corporate, can be tax-deductible in the U.S., and you can allocate donations to specific initiatives. Save the date for June Zoomustahan, Friday, June 17, 5 p.m. Los Angeles, 8 p.m. New York, and Saturday, June 18, 2022, 8 a.m. in Manila. Thank you so much, everyone. We appreciate you and hope to see you guys again in our next Zoomustahan.